Here's some more tips for emergency medicine sub-I's is that medications and interventions don't just have risks and benefits, they also have assumptions, right? The classic one is opiates, morphine, right? The benefit is pain control. The risk is you might stop breathing. Manage that risk, right? But assumptions are also critical. Now, what do I mean by that? I mean hyperkalemia medications, right? Let's talk about Lasix. Risk, maybe blood pressure gets a little lower. Benefit, K can go down. Assumption is that you have enough time for it to work and that your patient's able to urinate. Your dialysis patient who's missed dialysis, who hasn't peed in 10 years, is probably not going to get a meaningful benefit from Lasix. K-exolate is another one. Benefit, K go down. Risk, I guess they could choke on it when they try to do PO. But the assumption is you have enough time for that medication to go into stomach, go into gut, and then take some of that K into the gut and you poop it out. That is a lot of time that we probably don't have. Albuterol is another one. The risk is could make you more tachycardic. It could increase your myocardial oxygen demand. Benefit, it will shunt some of that K back into cells. The assumption is you are going to fix the underlying thing that's causing the hyper K by the time those receptors decide, we don't need to shunt all our K into the cells. That will come back out. You should figure your stuff out by that time. Calcium chloride to stabilize the cardiac membranes. We all love that one, right? Assumption is you have a central line or some kind of access that's going to be amenable to that, right? Calcium gluconate also can do that, but the assumption is that you don't need to emergently stabilize the cardiac membranes as much because you only have a third as much elemental calcium, right? Because chloride is a smaller molecule, gluconate is a bigger molecule, so comparatively, calcium gluconate, you have less calcium in that. Insulin, similar to albuterol, will shunt that potassium into your cells. The risk is hypoglycemia. The assumption is, again, like albuterol, that you're going to fix the underlying thing by the time that wears off and the K comes back out of the cells. And lastly, dialysis. The risk is you are taking someone potentially off the floor when they're critically ill. The benefit is it's a definitive management. The assumption is you have some kind of access or ability to put in a Quinton. The assumption is you're familiar or comfortable with that procedure, or you're even in a facility that has nephrologists. So I've been rephrasing a lot of my questions that way. What are you assuming is going to happen when you give that med, and what evidence do you have to support that claim? Because just risks and benefits is like M1, M2 stuff.